and then raised in Layton, Utah. She completed her Bachelor of Science degree in chemistry from the University of Utah and her Doctor of Pharmacy at the University of Utah College of Pharmacy. She's excited to continue her training as a PGY1 pharmacy resident through the University of Utah Health. And then following her PGY1, she plans to pursue a PGY2 in emergency medicine. And she is going to give a presentation called Who You Gonna Call? Clot Busters, Thrombolytics for Pulmonary Embolism-Induced Cardiac Arrest. So thanks, Ashley.
Thank you, Stacy. So as Stacy mentioned, my name is Ashley Jackson. I'm a PGY1 pharmacy resident at the University of Utah. And for my disclosures, my CE mentor, Helen Howe, and myself, neither of us have any relevant conflicts of interest. And as far as the off-label uses of medications, we will be discussing alteplase as well as the usage of tenactplase. So for my learning objectives today, for a pharmacist, the first one will be to explain the pathophysiology of cardiac arrest secondary to pulmonary embolisms, also known as PEs. Second, describe the role of thrombolytics in cardiac arrest secondary to PEs. Third, identify patients with contraindications for thrombolytics. And fourth, design a patient-specific thrombolytic plan. For technicians, the first learning objective will be describe the mechanism of action of thrombolytics. Secondly, identify brand and generic names for common thrombolytics. And lastly, demonstrate appropriate storage and handling requirements for thrombolytics. So on this slide here, I just listed the common abbreviations I will have throughout my presentation. Feel free to refer back to this slide in the handouts if you have any questions throughout. And so we will first get started with looking at the epidemiology behind pulmonary induced cardiac arrest. And so less than 5% of patients with acute pulmonary embolisms progress to cardiac arrest. Cardiac arrest secondary to PEs attribute to 5 to 13% of unknown cardiac arrest a year. And then when assessing this, 5 to 6% have been identified as definitive acute PEs in the hospital. Mortality rate of cardiac arrest secondary to PEs is 65 to 95%. So although this is rare, this clinical disease state, or rather presentation, has a high mortality rate and warrants discussion and hopes to be the utmost prepared as well as achieve better patient outcomes. And so when we look at the pathophysiology, and we really question, like, okay, what's going on in the body that leads to this pulmonary embolism-induced cardiac arrest? And so when you think about a pulmonary embolism, or rather DVT in a circumstance, the thrombus breaks off and travels up the inferior vena cava, then to the right atrium, over to the right ventricle, and then eventually becoming caught in the pulmonary artery. This causes an increase in pulmonary vascular pressure and leads to backflow of blood within the right side of the heart. This backflow then leads to increased right ventricular pressure and dilation of the ventricles, and ultimately right-sided heart failure, which causes decreased stroke volume, decreased cardiac output, and we're also seeing a decrease in blood pressure. And as this occurs, the sympathetic system kicks in and basically causes sinus tachycardia and vasoconstriction in an attempt to compensate for this presentation. This process can be summarized in the 5 steps I have listed on this slide here. So first, we'd see an increase in RV afterload, RV dilation and neurohormonal activation, as well as third, decreased RV output and left ventricular preload. Fourth, we see a decrease in our cardiac output. And then lastly, this leads to cardiogenic shock, which will lead to cardiac arrest, and then eventually could lead to death. And so for our first audience response question, it will be, which statement is correct regarding the pathophysiology of pulmonary embolisms? A, initially the patient has decreased RV load. B, AV node activation decreases and leads to a clot. C, leads to hypovolemic shock. Or D, increased right ventricular afterload. I'll give it just a second longer. Okay, so we can see that the most common answer is D, in which D is correct. I see everyone kind of switching things around there. And so going back to the explanations for each one. So initially the patient has decreased afterload was the first answer here. But it actually is an increased RV afterload, not a decrease. And then B, AV node deactivation is not a cause that was previously discussed. And C, it leads to cardiogenic shock rather than seeing hypovolemic shock in our patient presentation. And so when looking at the symptoms of pulmonary embolisms, a patient can present with several of the following symptoms and may include or exclude a few of them as well. And so some of the ones that you can see would be just pleuritic pain, cough, orthopnea, maybe some calf or thigh pain, as well as swelling, wheezing, transient and persistent arrhythmias, syncope, or either hemodynamic instability, to name a few of those. When looking at risk factors for this population, this can be divided into two categories. So we have transient risk factors as well as chronic risk factors. When we take a look at the transient risk factors, we first can see those with surgery or who have received general anesthesia for greater than 30 minutes, those who are hospitalized with an acute illness, patients who have had a C-section or on estrogen therapy, and then as well as pregnancy, and those who have a leg injury with decreased mobility for greater than or equal to 3 days. When assessing chronic risk factors, this would include those who have active cancer, inflammatory bowel disease, autoimmune disorders. This could include like rheumatoid arthritis, for example, chronic infection or chronic immobility, such as a spinal cord injury. And so when we look at the types, or rather pulmonary embolism as a whole, we can basically divide it into 4 categories. And so in the first category, we will go from least to most severe. On the left, we have PE with normal hemodynamics and RV function. And so this is a patient that is considered low risk. They're presenting with normal hemodynamic function as well as normal RV function. In the second category, we have submassive PEs, in which this patient can have RV dilation, but you can also see some stability within their hemodynamics. And then in the massive PE category, we also have maybe some instability with hemodynamics. We're seeing dysfunction within the RV, maybe some dilation as well. And this patient would be more likely to need acute care for their pulmonary embolism. And then in the last category, we have cardiac arrest. So in cardiac arrest, following like a pulmonary embolism, you start to see abnormal hemodynamic presentations. You're looking for, some of those signs and symptoms that we've listed on the slides, as well as RV dysfunction and dilation throughout. And so one of the key things with pulmonary embolism induced cardiac arrest is really being able to diagnose whether or not this is a PE. And so it is actually very difficult to diagnose a PE induced by cardiac arrest. Other cardiac and pulmonary diseases may have signs of RV overload or dysfunction, and so this may kind of muddy our picture. We also have to use clinical history and assessment. That's assuming that you either have someone that came into the hospital with the patient or that the patient was somewhat stable before going into cardiac arrest. And so really assessing their past medical history as well as the symptoms that they presented with or symptoms that they had at home if it was witnessed by another individual. And then assessing capnography. And so looking at basically the use, or rather capnography is looking at the use of a sample chamber, or rather sensor that's placed in a mask that will look at the amount of CO2 that's being expired. And so when assessing this, or rather like the low end title, it's a sign of low oxygenation. And so this is something that we can assess throughout cardiac arrest as we give breaths and compressions. Usually like a respiratory therapist or anesthesiologist will kind of be on top of this. And so listening for signs as to whether or not the patient is being properly ventilated throughout. can lead to diagnosing a pulmonary embolism in the setting of cardiac arrest. And then lastly, we can look at echocardiograph to further assess. And so when looking at an echo, some of the diagnostic criteria for RV dysfunction, there are a few keywords that as pharmacists will want to pay attention to. And that is maybe hearing RV wall hypokinesis, RV dilation, listening for pulmonary artery hypertension, and then just maybe any other factors that kind of go along with the pathophysiology of pulmonary embolism induced cardiac arrest. And so really keying in on some of these keywords to help guide, whether or not we're moving down one algorithm or perhaps changing the direction in which we are managing the patient. And so just to kind of go over, so thrombolytics and pulmonary embolism induced cardiac arrest is typically something that we will think about. And pulmonary embolism is a potentially reversible cause of cardiac arrest. So assessing how we can reverse this presentation. Chances for ROSC and survival may be significantly higher if a PE is present and can be treated. It's actually not well established in our current literature. And the overall survival rate is actually pretty low. And so when looking at guidelines, we'll take a look at the adult advanced life support recommendations, in which they say survival with favorable neurological outcome at 30 days, as well as survival at 30 days. And lastly, survival to hospital discharge has very low certainty of evidence. And in assessing the treatment recommendations based on guidelines, they recommend that we administer fibrinolytic drugs for cardiac arrest when pulmonary embolism is a suspected cause of cardiac arrest. And once again, this is a weak recommendation with very low certainty of evidence. So when we take a further dive, or rather step into the recommendations from the adult advanced life support, we see two recommendations. And so the first one is that patients with confirmed pulmonary embolism as a precipitant of cardiac arrest, thrombolysis, surgical embolectomy and mechanical embolectomy are reasonable emergency treatment options. And then lastly, we see that thrombolysis may be considered when cardiac arrest is suspected to be caused by pulmonary embolism. And so these recommendations really highlight the focus and importance of being able to diagnose whether or not the patient is actually having cardiac arrest due to pulmonary embolisms. When we take a look at the European resuscitation guidelines, they basically break it down into 4 areas. And so we are looking at airway, breathing, circulation, and then thrombolysis. Their recommendation is that when a PE is suspected cause of cardiac arrest, thrombolytic drugs should be administered. Once again, this is also a weak recommendation with very low certainty of evidence, but all the more consistent with the adult advanced life support recommendations as well. And so when we take a step further within thrombolytics and we ask ourselves, well, how does this work and how would it be beneficial for a patient presenting with a pulmonary embolism induced cardiac arrest? And so when looking at the mechanism of action, we really see that it initiates local fibrinolysis by binding to fibrin in the thrombus, or AKA clot, and then converts the entrapped plasminogen to plasmin. And so if you take a look at this diagram here, on this line here, we have our fibrin, which signifies our clot, and then we have our plasminogen and plasmin. And so some of the key, or rather 2 of the key primary drugs that we use in the United States for thrombolytics will be alteplase, also known as Activase, and tenacteplase, also known as TNCase. And these 2 drugs can come in and change plasminogen to plasmin, which will lead to the fibrin degradation of the products. And so when looking at the pharmacokinetics and pharmacodynamics of these 2 drugs, for alteplase, the duration is greater than 50% present in plasma, is actually cleared in approximately 5 minutes after the infusion has been terminated. And within this, 80% is cleared within 10 minutes. And fibrinolytic activity persists for up to 1 hour after infusion is terminated. And when assessing the half-life, it actually has a pretty short half-life with an initial half-life of 5 minutes. In comparison to alteplase, when looking at tenactoclase, the half-life elimination is actually classified as a biphasic half-life elimination, in which initially it is 20 to 24 minutes, and then the second half, or rather terminal phase, ends up being 90 to 130 minutes. And so I highlight this because understanding the half-life is important here, as the effects can persist past the PK half-lives. For example, TPA half-life is shorter, but the residual alteplase, or rather activase, within like an ischemic brain injury, for example, may still be present and can actually warrant reversal. And within like different guidelines and hospital protocols, if it's given within 12 hours, you can actually reverse it, whether you're using like TXA or the cryoprecipitate, as well as a few other regimens that are possible. And so really understanding the PK/PD and how to reverse the medication if necessary is important, and acknowledging this. And so for our second question, it is, which of the following is the mechanism of action for thrombolytics? Is it A, reversible inhibition and free and clot-bound factor 10A? B, does it bind to catalytic and anionic exosite of thrombin? C, converts plasminogen to plasmin? Or D, potentiates the action of antithrombin 3 and thereby inactivates thrombin, as well as other coagulation factors in plasmin? All right, it looks like everyone is paying attention. The correct answer is letter C, so converts plasminogen to plasmin. And so when assessing the contraindications to giving thrombolytics, or rather fibrinolysis, there are a few in which guidelines highlight, and also the package insert highlight, as being important contraindications. And so first, being active internal bleeding. Of note, this excludes menses. And then history of recent stroke within 3 months, except when within 4.5 hours. Third, intracranial and intraspinal surgery. Fourth, serious head trauma or facial trauma. And the next would be the presence of intracranial conditions that may increase the risk of bleeding. For example, intracranial neoplasm, or maybe an aneurysm. And then additionally, we have known bleeding diathesis, as well as severe uncontrolled hypertension and suspected aortic dissection. And so for our next question, a 60-year-old male has arrived to the ED with suspected cardiac arrest secondary to pulmonary embolism. He presents with a large laceration on his forehead. What would you consider prior to administering thrombolytics? Is it A, history of recent stroke within 3 months? B, active internal bleeding? C, serious head trauma / facial trauma? Or D, all the above? Okay, it looks like we have a mix here. So everyone either selected serious head trauma and facial trauma, or D, all the above. And so the correct answer that I was going for here was actually D, all the above. And so really just highlighting the importance of understanding our patient's history and doing so before we make any recommendations to the team. When looking at management of pulmonary embolism-induced cardiac arrest, as I kind of alluded to a little earlier in my presentation, we have two key factors, rather two main drugs that we utilize, in which the first is alteplase and the second would be tenactoclase. when looking at the labeling, pulmonary embolism associated with cardiac arrest is actually an off-label use for both of the medications. When looking at alteplase, or rather Activase, the dosing scheme is 50 milligram bolus over 20 minutes, and then you continue CPR. After 15 minutes, if return of spontaneous circulation has not been achieved and the medical team decides to continue CPR, then you would repeat a 50 milligram bolus. And then assuming that you achieve ROSC, this would be followed by systemic anticoagulation such as heparin. And then for tenactplase, this is more of a weight-based dosing. And so you'd administer one single bolus, and it's based upon the patient's weight, or rather being able to estimate the patient's weight if you do not have them, say, an Epic or whatever like chart system that you're using. And so, for example, if the patient weighs 65 kilograms, then your dose, or rather your single bolus, would be of 35 milligrams. And this too would be followed by systemic anticoagulation after achieving ROSC, most likely with heparin. And so for our next question, what is the brand name for tenactplase? Is it A, Activase, B, Tencase, or C, Coumadin, and then lastly, D, Retavase? Okay, and so we see that the most common answer here is Tencase, in which that is correct. And so Activase was alteplase, C is Coumadin for warfarin, and then D is Retavase, which is Retaplase, or also known as another fibrinolytic that we actually do not use. And so when we kind of take a step back and we, think about guideline recommendations, most of the recommendations that they listed basically had a low level of evidence, or rather low certainty. And so then we begin to question, well, what evidence surrounds the use of thrombolytics in pulmonary embolism-induced cardiac arrest? And I have a few studies here that we'll go over. And the key with each study is that we're either highlighting dosing, we're also having to take a look at bleeding risk in the patient population, as well as some of the studies highlight ability to discharge a patient after, and then like a 30-day follow-up following pulmonary embolism-induced cardiac arrest, just to get a full scope of the literature that we have surrounding this area, or rather this topic. And so when assessing the 2003 Janetta and researchers, this study was actually a retrospective cohort in which the population consisted of patients admitted to the emergency department of a tertiary care university hospital with cardiac arrest in the course of major pulmonary embolism. This was a relatively small study. We have 67 patients in which the intervention was alteplase versus no thrombolytics. The primary purpose of this study was to determine thrombolytic treatment if it increases the risk of bleeding complications, and secondly, if the risk of bleeding is influenced by the duration of CPR, and if thrombolytic therapy improves outcomes. And so in conclusion, they found that major bleeding complications appeared to occur more frequently in patients treated with thrombolytics, in which they were able to see like intracerebral bleeding, retroperitoneal bleeding, bleeding into a body cavity, and also, for example, solid organ and any other bleeding complications. ROSC could be achieved more often in patients who received alteplase, and this was 67% versus 43% in our patient population. And then survival to discharge was also higher in thrombolytic groups. And lastly, severe bleeding complications tend to occur more frequently in patients receiving thrombolytics, and the benefit of this treatment might outweigh the risk of bleeding. And so from this study, we can really see that bleeding is a concern in our patient population. But although bleeding is a concern and patients will be more often to bleed when given thrombolytics, we do see that ROSC can be achieved easier and also survival to discharge has a higher rate than if we were to choose no thrombolytic in this study. The next study is Sharifi and researchers from 2016. This was a retrospective cohort in which the population looked at adult patients with PEA and cardiopulmonary arrest due to confirmed massive PE. This is another small study in which our number of patients consists of 23 patients, and the intervention was either 50 milligrams of alteplase IV over 1 minute. And so for the purpose here, that was to assess the effect of low-dose tissue plasminogen activator on the clinical and echocardiographic outcomes of patients who presented with PEA and cardiopulmonary arrest due to confirmed PE. And so in conclusion, researchers found that ROSC occurred in all but one patient, and they found that no minor or major bleeding occurred in this patient population. Of note, they did see that 2 patients died in the hospital, and at 22 plus or minus 3 months of follow-up, as well as 20 patients, rather 87% were still alive at this point in the study. And then lastly, they found that rapid administration of 50 milligrams of TPA is safe and effective in ROSC and PEA due to massive pulmonary embolism, leading to enhanced survival and significant reduction in pulmonary artery pressures. And so from this study, they were able to find that the 50 milligram of alteplase dosing given over 1 minute allowed for ROSC to be achieved in their patient population. Contrary to the last study, they did not see any minor or major bleeding, but also keep in note this is a smaller patient population, and maybe they just did not have enough patients to find this outcome, or rather power the study from that regard. And next we have the 2018 Pepperton researchers. This design was actually a multi-center retrospective cohort study. The population, they assessed adults who received alteplase during pulmonary embolism-induced cardiac arrest at 16 medical centers. But although we assessed 16 medical centers, the study only consisted of 35 patients. And the intervention consisted of alteplase, in which they looked at a bolus-only dosing, infusion-only dosing, or either bolus with infusion. And the primary purpose of this study was to basically characterize the dosing in alteplase, as well as cardiopulmonary resuscitation survival, time to achieve ROSC, as well as documented occurrences of minor as well as major bleeding, and then intensive care unit and hospital length of stay, and lastly, survival to discharge. In conclusion, this study found that 2 major bleeding events occurred in patients who received alteplase bolus with infusion, and then they also were able to achieve ROSC, all despite this bleeding event. And then patients received a cumulative dose of actually 100 milligrams on average, when assessing the bolus only, infusion only, as well as bolus with infusion dosing schemes. And then 3 minor bleeding events occurred, and this actually occurred in the bolus only and infusion only category. And then 46% of patients received alteplase via bolus only dosing strategy. And lastly, patients receiving alteplase for presumed or confirmed PE during cardiac arrest. The most common treatment was administration of a single 50 milligram bolus of thrombolytic agent. So this study highlights once again that thrombolytics can cause both minor and major bleeding within our patient population. And once again, we're seeing this single 50 milligram bolus dosing as a regimen that was proven to work well in the patient population of this study. And for the next study, we have Javidin and researchers, a 2019 study. This design was a retrospective observational multi-center study. The population consisted of adults managed by a medical intensive care unit with diagnosis of pulmonary embolism and confirmed on-hospital admission. This was a relatively larger study compared to the last few studies that we've looked at, in which the patient population consisted of 246 patients. As far as intervention, this study compared fibrinolysis versus no fibrinolysis. And when assessing what drugs were used, we actually see that 14, or rather 24% of the population received alteplase, 74% received tenacteplase, and then only 2% received streptokinase, which is actually a fibrinolytic drug that we do not use here. And the purpose of this study was to look at the primary endpoint of 30-day survival, irrespective of the Glasgow-Pittsburgh cerebral performance categories. And then secondly, to look at survival at 24 hours, as well as length of stay in the ICU and neurological outcomes. And so through this study, we were able to conclude that 30-day survival rate was higher in the thrombolysis group than those in the control. And so this is assessing 16% versus 6% in our patient population, with a p-value of 0.005, which would be statistically significant from this circumstance. And then also looking at the good neurological outcome was not significantly different when comparing the two categories, in which we see 10% versus 5%, and we have an adjusted relative risk score of 1.97. And so from this study, we were able to see that basically administering fibrinolytics we were able to achieve ROSC, as well as have a 30-day survival rate in our patient population here. And so this is also in support of fibrinolytics throughout. And next we have the 2021 Kataria and researchers, in which this design was a multi-center retrospective chart review. The population consisted of adults with suspected or confirmed pulmonary embolism who experienced cardiac arrest. This is another small study in which we had 27 patients, and the intervention consisted of either alteplase or tenacteplase. The primary endpoint was survival to discharge, and the secondary endpoint was evaluated attainment of ROSC, dosing strategies, and then as well as the incidence of major bleeding events. So in conclusion, they found that among 11 patients, so 41%, they were able to achieve ROSC, and then 7%, or rather 2 patients, survived to hospital discharge. And then third, confirmed PE, an initial presenting rhythm of pulseless electrical activity, also known as PEA, and administration of alteplase within 5 minutes of cardiac arrest was the most common frequency in which, or rather how often it was given. And then thrombolysis may have facilitated ROSC, but survival to hospital discharge was actually pretty low. Excuse me. And so from this study, we were able to see that survival to discharge is actually pretty variable despite giving thrombolytics, whether it's alteplase or tenacteplase. And then we were able to see that they often gave thrombolytics within 5 minutes of cardiac arrest. And so just acknowledging the dynamics within the team, as well as your patient workup throughout, to see how fast, or rather how common other researchers or studies gave alteplase, rather tenacteplase, in this setting. And then next we have the 2021 DePaz and researchers, in which this was a retrospective observational study. The population consisted of adults with confirmed or highly suspected pulmonary embolism as the primary cause of cardiac arrest, and then those who had received either with or without emergency thrombolysis. This is another small study in which we had 16 patients, and the intervention was alteplase. The purpose of this study was to compare the outcomes after cardiopulmonary cerebral resuscitation, also known as CCPR. Of note, CCPR is basically, rather in contrast to CPR, it's only using the compression component of CPR, and so it eliminates the mouth-to-mouth ventilation. And so that's important to remember in this study as we assess our ability to achieve ROSC and how the study went through cardiac arrest protocols. And so in conclusion, thrombolytic therapy in patients with cardiac arrest secondary to PE. And then in conclusion, we found that ROSC occurred in 100% of patients who received thrombolytic therapy, and in 88% of the non-thrombolyzed patients as well. And then mortality rate of patients who received thrombolytic therapy versus non-thrombolyzed patients at a 24-hour mark was 25% and 50%. And then thirdly, we were able to see that at time of discharge, the mortality rate was actually the same in both groups. And lastly, the intra-arrest thrombolysis resulted in a higher likelihood of ROSC and a higher 24-hour survival rate in adults with cardiac arrest secondary to acute PE. And so from this study, we were able to see that the mortality rate is actually the same between the two groups when utilizing thrombolysis, but we are still in support of using fibrinolytics from this circumstance, in which there's a higher 24-hour survival rate in patients who have cardiac arrest secondary to PE, despite using alteplase versus no alteplase in the study. And for the last study we will look at is the 2021 Bacam and researchers, in which this was a systematic review. The population for this systematic review consisted of a search in PubMed that was conducted for clinical studies evaluating thrombolytic therapy for pulmonary embolism, or rather circulatory arrest. And then the intervention, they basically looked at accelerated alteplase regimen of 0.6 mg per kg. And then the max dosing consisted of 50 milligrams in 15 minutes, or either 100 milligrams given over 2 hours. And so the purpose of this study was to define a regimen that is compatible with CPR. And that's really acknowledging the hemodynamics and pharmacokinetic properties within our patient during this time. And the conclusion of the study was that a strong rationale is provided that the accelerated protocol in this regimen of choice for patients with PE-induced circulatory arrest was actually best. And so from these studies, we do see that, we have a high risk for bleeding, whether it's major or minor bleeding in our patient population. Additionally, the studies highlight that although we can achieve ROSC, there's still a high mortality rate when using fibrinolytics, but we are more often able to achieve ROSC in patients who receive thrombolytic therapy throughout. And so as we think about the studies and the primary literature that we just reviewed, you can reflect on the dosing regimens and say, I'm not really sure what regimen was the most popular. We have a few in which, we're using tenactplase versus alteplase, and maybe some other drugs that we actually do not have FDA approval for in the United States. But that still kind of leads you to wonder, well, LexiComp says this, the primary literature says this, and so where would I fall into this whole, dosing scheme? And so the primary question here would be, what dose should we use? And so just reviewing the literature that we just, kind of went through, and the dosing schemes that were used throughout. And so when looking at this slide here, one of the key takeaways that we see is that with alteplase dosing, our dosing consisted of primarily a 50 milligram push, in which we have examples of it being pushed over 1 minute. We also have examples in which we have, the bolus versus infusion, or either the combination of bolus and infusion. But we're really seeing this primary dosing of alteplase 50 milligrams being the kind of go-to dosing in these articles. And then of note, we do see alteplase at a max of 100 milligrams. But yeah, really highlighting the 50 milligram bolus, and then tenactplase, in which they use a median dose of 45 milligrams in the last study here. And then when looking at the other studies that we have, also continues to highlight the bolus dosing for alteplase, in which we also see that 50 milligram bolus dosing as well. But then we also come across a few instances in which, studies either did not highlight the tenactplase dosing that was utilized, such as in the Kataria and researchers, or either in which, alteplase dosing strategy was unknown. And lastly, in this study, we also see some of the weight-based dosing schemes used throughout. And so this basically highlights that the alteplase 50 milligram dosing scheme was most common. And with tenactplase, we see on average about 45 milligram bolus dosing to be the most common dosing schemes throughout. And so for our next audience participation question, it is JT is a 60-year-old male who presents to the ED via EMS and cardiac arrest. And the partner states that he has a history of PEs, but has not been taking his medication. Bedside ultrasound shows RV strain per MD. What is the most correct course, or rather answer, for this question? And would it be to start an epinephrine drip stat, provide chest compressions and breathing at a ratio of 10:1, stop ACLS in 60 seconds, or D, administer a 50 milligram bolus over 2 minutes of alteplase and continue CPR? After 15 minutes, if ROSC is not achieved and the medical team decides to continue CPR, repeat the 50 milligram bolus and then administer therapeutic IV anticoagulation. Okay, and it seems that everyone has picked the letter D. Which is the most correct answer in this circumstance. And so really taking into account the dosing schemes and, being able to discuss and communicate with the team as to where we are within our cardiac arrest protocols and algorithms. And so although, dosing schemes and understanding what drugs that we utilize in pulmonary embolism, cardiac arrest is extremely important, and we also have to keep in mind the operational considerations. The first operational consideration being the preparation. And so when looking at preparation for alteplase actually comes in a 50 milligram vial as well as a 100 milligram vial. And so it's important to highlight that using aseptic technique is always our go-to. Also with the 50 milligram vial, you use a large bore needle and syringe to withdraw 50 mils of sterile water for injection. And then this is inserted into then you insert the syringe into the stopper of the 50 milligram vial of Activase, and you inject the contents, making sure that if there is not a vacuum present, then you do not use this vial and it's considered unusable. And also highlighting the fact that you have to gently swirl the solution. So this is not one that you can, insert the syringe with the sterile water, give it a good shake and call it go. But just acknowledging that it recommends, or rather manufacturer recommends, that you have a gentle swirl. And so when looking at the 100 milligram vial, you actually reconstitute Activase immediately before administration, which is also consistent with the 50 milligram. And additionally, you are also using the sterile water for injection. But one caveat here is that you are administering it with this. Basically, if you see here, you have the center stopper. And so this is being utilized to achieve, or rather reconstitute, the alteplase. And so this is something that you have like the transfer device for, and it comes in the vial, or rather in the packaging for alteplase. This is contrary to the 50 milligram vial. And so just being able to acknowledge the differences between the 50 milligram vial versus the 100 milligram vial. This is important because, we always have shortages throughout, and acknowledging, well, maybe you're used to reconstituting the 50, but understanding the differences between the 100 versus the 50. And then the ultimate final concentration for alteplase here is the 1 milligram per mil. When we take a look at tenactplase is also kind of unique in its ability. You remove the shield assembly from the supplied BD 10 mil syringe with twin pack dual cannula device. And then it's aseptically withdraw 10 mils of sterile water for injection. And then using the BD 10 mil syringe, you're basically injecting the entire contents, or rather 10 mils, into the vial, and then diluting the powder that way. This is also another one in which you'd want to gently swirl the contents until they're completely dissolved. And a caveat here with tenactplase versus alteplase, that your final concentration is 5 milligrams per mil. And so this picture depicts basically what the syringe looks like, and the twin pack shield, as well as like the green cap that's associated with it. And so for the next question, it is, which medication contains a transfer device to allow for reconstitution? Is it A, Activase, or rather Alteplase 50 milligram vial, B, TNKase, or rather Tenactplase, or C, Activase, Alteplase 100 milligram vial, or D, Lovenox, also known as enoxaparin? Okay, and so the most correct answer here is the Activase, or rather Alteplase 100 milligram vial. And then of note, I know that some of you did vote for the 8% Tenactplase with the BD syringe, which also is not wrong, but something that kind of noticed after I finished all of the slides and realizing that technically a transfer device is utilized for both. But the most correct answer and the purpose of this question was really to highlight that Activase 100 milligram vial has that transfer device, in which the Activase 50 milligram vial, we do not have the transfer device. And so being aware of that before reconstituting is the primary purpose of this question here. And so additionally, after we think about, how do we reconstitute these medications and prepare them for our patients? And we also have to think about, how do we avoid medication errors? I mean, Tenactplase, or rather fibrinolytics as a whole, are, very dangerous medications. And so what can we do within pharmacy to avoid any medication errors? And so I've listed a few things that we can consider. First would be, do not use the abbreviation TPA. Second would be to refer all three tissue plasminogen activators by their brand name, generic name, and or both. And so this highlights, avoiding T and K for abbreviations for TNKase, and then also like TPA, avoiding those abbreviations as well. And also removing these abbreviations from standardized order sets. This is very important for institutions that maybe carry both fibrinolytics, and then stating the indication on the prescription order to ensure that the correct drug is chosen. And this also goes into the correct dosing scheme, right? And so if we're adding the specific indication, or rather checking that box in EPIC that says, this is going to be for pulmonary embolism-induced cardiac arrest, we may be more likely to catch any medical, or rather medication errors associated with that order. And then lastly, consider the use of alerts for TNKase in electronic prescribing order entry systems, and or automatic dispensing cabinets. An example of that is basically like warning, like frequently confused with Activase, also known as Alteplase, verify the correct dosing for the appropriate indication. And when assessing the storage, it's important to note that the storage criteria, or rather preferences for both, would be a little different. And so intact, we have a room temperature vial. It can be stored in 30 degrees Celsius, or rather 86 degrees Fahrenheit. This is consistent for both Alteplase as well as Tenactplase. And then intact vials can also be refrigerated between 2 degrees Celsius and 8 degrees Celsius, or rather 36 to 46 degrees Fahrenheit. That is consistent once again for Alteplase and Tenactplase. And then when assessing the protection from light, we see that Alteplase must be protected from light, whereas Tenactplase does not have to be protected from light. And then in assessing how do we handle, or rather store, reconstituted vials. Reconstituted vials for Alteplase can be stored within 36 to 86 degrees Fahrenheit and used within 8 hours. But for Tenactplase, it actually has to be stored in the refrigerator right away and used within 8 hours as well. And then for solutions, we see that for Alteplase, we can basically store it within a plastic syringe. And when stored in a plastic syringe, it can be retained approximately 94% of its fibrinolytic activity. This is not the case with Tenactplase, in which it should not be stored in a plastic syringe. And then of note, with both alteplase and tenactplase, we really wanted to highlight that this is a time-sensitive medication. And so it has to be used within 8 hours once it's reconstituted. And that, that goes whether or not the medication should be stored in the refrigerator, or if it's, say, tenactplase and it has to be, not protected from light. And so really acknowledging that with either medication that you have, it has to be used within 8 hours. And then next, we just really wanted, or rather, I wanted to discuss spoilage. In looking at spoilage, Genentech spoilage replacement program is something that can be utilized for both alteplase and tenactplase. And so an example of this is if the prescribed, or rather prepared, medication for a labeled indication is not used, or rather administered due to like an unforeseen patient clinical circumstance, then the Genentech spoilage replacement program system can be utilized, and you just have to retain all of the labeled syringes, bags, and packaging associated to the medication, and then you have to basically complete the program form. And it's also important to note that replacement will not be shipped for the following reasons, such as use for an off-label indication, which just to remind you, for alteplase and tenactplase and pulmonary embolism-induced cardiac arrest is listed as an off-label indication, and then it cannot be returned if any portion of the medication is used. And so for our next question, Central Pharmacy received a stat order for alteplase. The IV center began to prep the dose by reconstituting the vial. As soon as the vial was reconstituted, the order was canceled. How should the technician store the vial of reconstituted alteplase? A, discard in the sharps container. It cannot be reused. B, store at room temperature on the counter, reuse in 24 hours. Or C, place in the freezer. It can be reused in 45 days. Or lastly, D, store at room temperature and protect it from light. If unused after 8 hours, discard. Okay, and the correct answer is D. So store at room temperature and protect it from light. If unused after 8 hours, then discard. And so when thinking about how to properly handle, say, alteplase or tenactplase, this medication is listed on the do not tube list in the pneumatic system. And so we basically have two reasons why we do not tube this medication. One would be the cost of the medication, and it would be a very costly drug to get caught, or rather lost, within the tube system. Mind you, this is also a very time-sensitive med, and so taking that into account, as well as drug alteration. And so fibrinolytics are purified glycoproteins. And so anytime you have a glycoprotein, or rather a medication that has this very large protein structure, it is a medication that should not be tubed, because you can actually denature this protein in the tube system. And so in summary here, you do not want to tube the medication due to A, cost, as well as B, the drug alteration, because of the size of the protein. And so as a review, we have several limitations from the literature surrounding pulmonary embolism-induced cardiac arrest. Most of the studies consisted of very, very small sample sizes. And so therefore, we feel like we are unable to rather justify some of the outcomes, because the studies weren't able to, say, power some of the outcomes that are associated, rather conclusions that researchers were able to make. And then also researchers rarely provided definitions of IV bolus in their studies. This is a limitation because we were unable to see whether or not, it was an IV bolus given over 1 minute versus 2 minutes versus 3 minutes, and really being able to assess the different dosing regimens throughout. And it's also important to highlight the barriers to care. And so cardiac-induced pulmonary embolism requires a timely diagnostic as well as retrieval of drug. This was something that we could see in one of the studies in which the team was actually given fibrinolytics within 5 minutes of cardiac arrest. And so that, included that timely diagnosis, as well as being able to quickly retrieve the drug, which can be a barrier to patient care. When assessing this requires a physician diagnosis. Thrombolytics typically are not stored in crash carts, and so having to coordinate with central pharmacy is extremely important. And then sometimes we'll see the instance in which pharmacists actually will have to leave a code in order to acquire the drug and potentially even compound it at bedside. And so keeping this in mind, in which they would all be barriers to care and also a barrier to the timely administration. And this just goes back to really having close communication and between the team, the physician and pharmacist, as well as, the team that we have in central pharmacy. And then lastly, a barrier to care would be shortages. And so it's also important to monitor for drug shortages using our drug information center, as well as pharmacy purchasing team. And this goes back into understanding how to prepare both, say, a 50 milligram vial versus 100 milligram vial, just to alleviate those barriers to care within. And then in summary, we see that pulmonary embolism is a potentially reversible cause of cardiac arrest. Thrombolytics may be administered in patients with pulmonary embolism-induced cardiac arrest. And then using a patient's clinical history and past medical history is very important when assessing or diagnosing a PE. And then thrombolytics may facilitate ROSC and improve patient outcomes. And lastly, pharmacists and pharmacy technicians play a key role in patient care here and definitely coordinating care throughout the entire team. And I just have the objectives that we've covered throughout this presentation again. And what questions do you all have for me? I'm not seeing any questions right now, but if anything comes up, definitely feel free to shoot me an email. I'd be happy to discuss anything with you. I've also got my list of references here. And then we are almost to that CE code that I know you're all itching to jot down here. And so the CE code is AJ9838. And thank you all for listening to me, and also a special thank you to my mentor, Helen Howe, for assisting me with this presentation, and everyone else. Thank you.